Hey everybody, we're going to talk about a topic that's not actually talked about that often in EMS, and that's abdominal pain. This is actually a topic that's kind of near and dear to me because just the abdominal cavity and what's all in there and all the stuff it does is pretty neat. And I don't think that we do a deep enough dive in EMS, talk about all the things that we can get called for with abdominal pain. The other thing with that is EMS traditionally, on a global scale, tends to dismiss a lot of things with abdominal pain. And so, with this lecture, my hope is that as we go through it, we're going to talk about some common causes and some good just treatment modalities that might change your perspective on some of these things. So, as we go through, we're going to talk about common signs and symptoms with acute abdominal discomfort. So, talk about belly pain stuff. And I'm going to give you some street smart practices to identify causes of abdominal pain because when we're looking at abdominal pain, sometimes it can be really confusing. Sometimes we just take a shortcut with that. But give you some good tools to be able to operate in the street and identify what's going on. We'll look at some specific treatments and protocols. And then, given a couple patient scenarios, hopefully we can get a good treatment plan together and identify a likely cause. So to talk about abdominal pain itself, it's the #1 cause of ER visits for 6 years there, and that's from the CDC. And that was pretty surprising because you'd think with the amount of chest pain calls and respiratory calls and just things like that, that those would eclipse and surpass it, but it's not, it's abdominal pain. But when we look at that, we actually think about what's going on. The belly has a lot of stuff in it. That's a lot of stuff and parts that can go wrong. We all eat. What we put in our bodies sometimes does not agree with us. And because there's no easy treatment of it, sometimes we just let those symptoms go and then we present to the ER. And a lot of the treatment results in surgery or admissions or things like that. So when you actually look at all the causes of it, it really kind of makes sense as to why this would be so common. Not only is it common for the ER, but it's a very common call type for us. It varies in severity. It can be very mild to quite severe to even life-threatening. And again, there's a lot of different causes that have it. So the signs and symptoms of abdominal pain is, well, pain itself, obviously, right? That's usually what we get called. People typically don't call us because they want to see us, although that is something that does occur infrequently. But we get called for belly pain. But there are also some other signs and symptoms that we might be called for that is a result of abdominal pain or a result of acute abdominal issues. And that just might be weakness or malaise. You might get some shortness of breath, some flank pain, some back pain, nausea, vomiting, dizziness, and then also nonspecific chest pain. Nonspecific chest pain, think of things like indigestion, but things that we might get called for, but that actually is attributed to some type of abdominal issue. So before we jump in any further, let's just go over a quick anatomy of the abdominal cavity because you have a lot of stuff going on in there. So #1, you have your aorta, right? So your descending aorta comes off your heart and travels right through the center of your abdominal cavity. And that bifurcates towards the bottom and goes down to your femoral arteries or it goes down to your legs. And then you got your inferior vena cava coming up. So you got two major vessels right there in the kind of the trunk of your abdominal cavity. We have your esophagus that comes down, that connects into our stomach. We've got a spleen, a pancreas, we've got our descending colon, we've got our small intestine in there, we've got the rectum, we've got a bladder, we've got kidneys in the retroperitoneal space. We got a lot of stuff in there, right? And that's why our abdominal cavity is squishy. These organs are solid or hollow organs. They move around, and they can also bleed a lot. So blood can hide in the abdominal cavity. We know that through trauma emergencies. So when I have someone complaining of belly pain due to trauma, I need to be thinking of things like belly bleeds. Because these organs are solid, some of these are solid organs like a liver, they have a ton of vasculature, so they get injured in traumatic injuries. Hollow organs and penetrating trauma, they can leak out and leach out the bile and the things in the stomach contents and the stuff that's in them, leading to infection and sepsis. So there's a lot of stuff in there and a lot of stuff to go wrong. Not to mention the fact that we have these two guys, visceral parietal nerves. So your central nervous system is connected to all of your organs. And so we have visceral nerves that go to your organ specifically. So you have a visceral nerve that goes to your appendix. You have a visceral nerve that goes to your liver. You got a visceral nerve that goes to your stomach and to all your organs. And then we have parietal nerves, and these are on the inside of your abdominal lining. Now, what that does for us is it makes an abdominal assessment very, very difficult because when they have pain, both of these nerve systems are firing and sending pain signals to the brain saying, my belly hurts. So we get there, we palpate, we're palpating both. So it can be somewhat difficult to pinpoint exactly where that pain is. So that's why we have to have a few street smart tips that's not taught in the book to try to kind of figure this out. But both of these nerves firing makes an abdominal assessment more difficult than, say, a cardiac patient where they're complaining of chest pain that's radiating. Not to mention the fact that with chest pain, we're kind of dealing with just like respiratory and cardiac issues. And from those two things, we can kind of figure out, as I say, respiratory problem or a cardiac problem. Well, in the abdomen, we have 4 different functions going on down there. Number one, we have digestion. So if we think about it, and not to be crass, but if we take our favorite food, like a steak, we take that steak, we chew it up, we swallow it, we start digesting it, and we take what was this awesome steak that comes out on a platter, and we turn it into something on the back end. And through that whole process, we're taking out nutrients and we're taking out all the things we need to make our body work. So when we think about it from the lens of like a factory, it's really miraculous how our body does that. We also have an endocrine system. Part of the endocrine system is housed in the abdomen. And in the endocrine system down there, we have things like the pancreas, which is putting off insulin to make my body stay in homeostasis with glucose production. I also have reproductive organs, things like my fallopian tubes, things like ovaries. So in female anatomy, we have reproduction down there. And then we also have waste removal. So we have a bladder, we have kidneys, and the kidneys are nothing more than a giant filter to get waste out of my body. I've got my rectum and I've got my colon, which are trying to remove solid wastes. So I've got all these things tied in working in the abdominal cavity. Now, as medics, we might be saying, well, big deal. What do I care about that? Well, I care because depending on the nature of the call, it's probably affecting one of these types of systems. So one street smart thing that we can do is called the glass P. Now, again, this is not something that's taught in a book. This was taught to me 20-something years ago by some guys out of Union Township, Claremont, but it works. So it's definitely not scientific, but what it does is it takes the overlay of the picture of the abdominal cavity and where the organs are and makes it a lot easier to try to remember at 2 o'clock in the morning. That's what we're going to walk through now. So one of the things we have to do is to divide the abdominal cavity into 4 quadrants. And we're used to this. So we divide it right down the center, and then we divide it across. And the belly button or our navel is our dividing part, right? So we have our right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. Goes without saying, but it's a common sense thing, sometimes gets forgotten. That's the patient's right side, patient's left side, not your right side. If you're facing a patient, their sides are going to be opposite. So remember, their right upper quadrant is their right upper quadrant, not yours. So what we do is we divide right through here, just like we did on the previous slide. So right where these intersect would be the belly button. Right upper quadrant, left upper quadrant. And then we draw this weird looking red line. Kind of like an Indianapolis Colt symbol, kind of like a stick figure shrugging his shoulders, saying, I don't know. But we draw this weird shape. And then everywhere it intersects is an organ. So if we think glass P, well, if I have an organ that starts with G, gallbladder. Next letter is L, liver. A would be the appendix. And then it gets a little weird with the S's. But if I'm in my left lower quadrant, the only thing down there that starts with S is the small intestine. Your stomach is not down there. I come up, stomach and spleen, interchangeable. You could make this one spleen and this one stomach, or this one stomach and this one spleen. It really doesn't matter. And then finally, we end with the pancreas. So when I do glass P, all I do is put my organs on these corners. Now, again, we said this isn't scientific, but what it does is it puts you in the ballpark of where those organs are. Of course, the liver comes across the right upper quadrant, but it also comes across the left upper quadrant. Okay. But if you palpate the right upper quadrant and they really say ouch because it's their liver that's inflamed, it at least gets us in the ballpark. The other way that you can use this is if I have if a patient's just complaining of belly pain, hurts all over. I'm palpating those quadrants, and if it really isolates in that right upper quadrant again, well, then I really don't worry about the other ones. So now I'm thinking of, okay, I either have a gallbladder issue or I have a liver issue. So that's the way this is designed. If I have pain in my right lower quadrant, I'm probably thinking appendix, and I'm kind of dismissing everything else. It's kind of like how you do dysrhythmias. If you're taking an assessment of somebody and their heart rate is 50, well, I'm starting to think of Brady rhythms and blocks. I don't care about tachycardias. I don't care about atrial rhythms at that point. Like, all that stuff just goes out of my head. That's not what we're dealing with. So, kind of likening these two together, if I'm palpating the quadrants and one quadrant has more pain response than the other ones, then I just want to isolate and think about the disease processes that are going on in that general area. Some other generally good ideas that are out there, obviously, don't start with just touching someone's stomach. Start with the mental status, our ABCs, and our history. So get a good focused assessment in. Really focus on the mental status, the ABCs, and history, and then get a good sample history. Making sure that we're going down that mnemonic, making sure we're getting the medications, the allergies, and the pertinent past history. In a lot of these cases, they've had previous issues. They've got maybe like colitis or irritable bowel syndrome, some type of disease process that maybe can point us and help us to figure out what's going on. They may have been hospitalized for kidney stones or gallstones or something like that. Again, that just helps us to get a good history. And then, if possible, palpate from the least painful area to the most painful area. So that way we can see where the biggest pain response is. That's not always possible. If they're complaining of pain all over, you got to start somewhere. But if they're saying, man, it really hurts in my left upper quadrant, then go to the opposite side. I want to go to my right lower and then palpate around to the left upper quadrant just to see where that pain's isolated at. Notice I keep saying the word palpation, palpation, palpation. We have to palpate stomachs, right? So just like on a respiratory patient, we have to listen to lung sounds to try to figure out what's going on. We need to be palpating the belly. So don't take the patient's word for it, their stomach hurts. That's what you were called for. Obviously, there's a complaint there. But if we palpate, that gives us a lot of information. I'm looking for things like distension. Is it swollen? What does it feel like? Does their stomach feel very rigid? A rigid, distended abdomen is typically blood until proven otherwise. Why do they have blood in their belly? Well, could be from trauma or medical reasons. If they have a lot of bruising, all right, now I'm starting to think of, is this an assault or what's going on there? So I'm trying to palpate the belly, feel different things. You may feel a pulsating mass with like a AAA. So these are all reasons to make sure that we do a good focused assessment to expose the belly, palpate the belly. So we got someone that hurts all over, right? So we get called for severe abdominal pain. The way we look at that, it's either acute or chronic. So acute, this is something that's been going on for a day or two. It's never happened before. This is an acute thing. And acute things are typically, for us, something to really be concerned about. Or it's chronic, right? So if they have hepatitis, for instance, if they have a little bit off topic with like a sickle cell problem, where their stomach just hurts all over because of a blood disorder. That's a chronic problem. They can identify what that is because they've dealt with it before. So we're looking, is this an acute issue or a chronic issue? Both get equal treatment, but it just helps to kind of narrow the field as to what's going on. try to use their OPQRST mnemonic. So OPQRST is a great mnemonic for pain. So anytime someone's complaining of pain, OPQRST is the mnemonic we want to use. If you have someone with altered mental status, though, or a seizure or something like that, OPQRST doesn't do anything for you. But for pain, it's great. For further clarifying questions, again, what's the pain feel like? Is it dull? Is it sharp? Does it feel like a stabbing pain? Like, where is it? Does it radiate anywhere? All those good clarifying questions, again, to help pinpoint what's going on. And then, like we talked about, evaluate for previous similar symptoms. So acute abdominal pain could be life-threatening, even if it doesn't present as life-threatening. So even though they're not bleeding out, even though they're not cool pill diaphoretic with profound hypotension, with severe tachycardia and altered mental status, it still could be life-threatening. In fact, we go on a fair number of abdominal pain runs that through QIC and through the QIC process, these people get admitted, get major surgery done that could be life-threatening. So our job as clinical providers is to try to catch that early, because if they sit in the ER and bleed out for 6 hours into their belly, it's harder for them to recover. We want to keep their recovery times down. We want to keep their hospital stay times down. We all work for a part of a healthcare system. And so if we can catch this early, we can get them treatment early, discharged to home early, keep their bills down, get them back reunited with their families, and also keep the hospital wait times and bed times down. So even though we might say, well, I don't care about that, right? I just want to ride the medic unit. I understand that. But like it or not, this is the hand we're dealt when we start looking at system-wide healthcare. And so we just have to understand that that's how these things work. Some treatment for acute abdominal pain is a 12-lead EKG, capnography, vitals, IV, glucose check, and then consider pain management. And you might be sitting here thinking, well, no, acute abdominal pain, that's a BLS run. Turf it, let the basics take it, and what am I going to do? Well, and that's the issue, is that oftentimes we tend to under-treat or under-triage these patients. And realistically, a lot of our abdominal pain patients are, in fact, ALS. And so, being ALS, we should consider ALS treatments, get a 12-lead, get Capno on them, IVs, glucose, and then consider pain management. So let's look at an example, right? So we get called for a male, 75-year-old male with abdominal cramping and weakness. Now, like it or not, I'm sure when these tones drop, you kind of roll your eyes. I can't believe we're going on another belly pain run, especially if it's 2 a.m. And I understand that. But don't judge a book by its cover. So we get there, patient's alert and already times 4, he's laying in bed, he's pale, warm, and clammy. So he appears sick. Okay. Patient states he thinks he has the flu, and he's keep having loose bowel movements. Again, something that presents as very BLS. This guy's got diarrhea. That makes sense why he might be pale, warm, clammy, laying in bed. When we take his vitals, we get a blood pressure of 100/58, a heart rate of 110 and irregular. His respirations are 22, O2 sat 94, and a capno of 27. Your vitals tell your story, right? We can't fake our vital signs. We can fake our history, we can lie about our assessment, but you can't fake what your body's doing. So when we get vitals like this, we have to stop and consider 100/58. That's low, right? Even though it's not clinically hypotensive, on a 75-year-old male, that's low. Most adults, most geriatrics are going to run hypertensive, and they run hypertensive because of atherosclerotic disease or arteriosclerosis. So just calcification of their and hardening of their veins and arteries. That's why they all take blood pressure pills. So when we have a geriatric who's borderline hypotensive, that should be a cause of concern. That makes sense that his heart rate would also be a little tachycardic. So I got borderline hypotension, or in this case, he is hypotensive. He is a little tachycardic. That's shock till proven otherwise. If we look at his other vital signs, he's a little bit shocky with his O2 sat being a little low. But the telltale sign of this is capnography. His capno is low. And the reason this guy's capno will be low is because he is in fact in shock. It's not due to hyperventilation. We talk capnography extensively with a respiratory patient, but capnography can be used to measure a whole host of things. Because he's breathing fast does not mean this is why his capno is low. His capnography is low because his cells are not producing energy. They're not taking in the necessary ingredients to have cellular aerobic metabolism. And if his cells aren't working, that means his cells are dying. And if his cells are dying, they can't put off the waste product of the body, carbon dioxide. And if they can't put off CO2, we're going to get low capno values. So a low capno value in the presence of hypotension and tachycardia is shock. So why would this guy be in shock? Well, let's look at it. He could have an abdominal bleed. So abdominal bleeds can be traumatic, right? So they could be hit by a car and you're bleeding internally. That makes sense. But don't forget, there's this whole other side of things like medical abdominal bleeds, things like esophageal varices, things like irritable bowel disease and diverticulitis that cause such inflammation of your colon and such inflammation of your small intestine that it literally rubs holes in those, causes ulcers that can literally perforate and bleed and leak your intestinal contents into your abdominal cavity. A bleed is a bleed. Blood loss is blood loss. We don't care if it came from being shot 3 times or if it comes from esophageal varices. Blood loss is blood loss. Your patients with an abdominal bleed may have coffee ground emesis. They may have dark tarry stool, and oftentimes will present with those. But sometimes your patient doesn't know. Sometimes your patient's embarrassed. Sometimes your patient doesn't want to talk about it. So sometimes they're also just altered. So don't the absence of coffee ground emesis or the absence of dark tarry stool does not mean that they don't have an abdominal bleed. This is especially true if a patient is on blood thinners, right? So maybe they were in a motor vehicle crash and had a sudden deceleration injury. They got that seatbelt sign. They're on blood thinners. There's a chance that they could have something. That's also true with falls. Older male falls, he picks himself up, but he's on blood thinners, didn't hit his head, but maybe he ran into something in his belly. That can cause issues. So sometimes abdominal bleeds take forever to manifest. Just because if it's a slow bleed or a slow leak, we can't keep up with clotting, it's going to take a while for that bleed to manifest itself. So let's look at another one. So we go on a 23-year-old female with abdominal pain. She presents alert and oriented with sudden, sharp lower right quadrant abdominal pain. So lower right quadrant, sharp. Her pain's been ongoing for several days. She's got constant cramping and sharp pains. She's pale, clammy, and hot. Her BP is 124/70, heart rate's 102, respirations are 22, O2 96. She's got a capno of 26 and a temp of 100.7. But like we just talked about with that 75-year-old male, who does in fact have an abdominal bleed going on, we see in this same patient that she's got a low capno value as well. Now the difference here is she's not hypotensive. She doesn't really have shocky vital signs, but she does have a low capno and she has a fever. So if she has a low capno, she's not hyperventilating. So again, this is shock until proven otherwise. So if we think, all right, if this is shock or has the potential to be shock, and she has a fever, we're probably dealing with what kind of shock? And hopefully you get to the conclusion that this is septic shock. So remember that shock is shock, right? That's your body failing to maintain compensatory mechanisms. That's your body's failure to maintain homeostasis. So she's in compensated shock. So what kind of an issue could be going on in her right quadrant abdominal or right lower quadrant causing septic shock? For her, probably appendicitis. So this is a common occurrence with over 300,000 visits annually, and all it is an inflammation of your appendix. Your appendix really doesn't have any known function, but it does gum up. It does get blocked up because it's kind of like a little sponge, and it's often caused by colitis, but not the only cause of it, but just greasy foods and just a dietary thing, to many cases causes appendicitis. As it becomes inflamed, it can actually burst, but this is the number one cause of emergency abdominal surgery from abdominal pain. So a patient presents with belly pain, oftentimes it's appendicitis, and they just take it right out. In her case, that's exactly what's going on. So it starts typically with a dull ache that often goes ignored. Over the last couple of days, it becomes a sharp, constant pain in her right lower quadrant. Sometimes it will have referred pain, where if you press on it, it'll start hurting other places because of those visceral parietal nerves. But this is appendicitis. And a burst appendix or an inflamed appendix, because you have inflammation in your body not being taken care of, can and often will lead to sepsis. And sepsis, left untreated, can and often leads to death. So we think of appendicitis as, oh, what's the big deal? It's a huge deal. Anything that we're going to do for this? Not necessarily, but the early recognition of it and the early suspicion of it will hopefully guide her to faster treatment at the emergency room. Other things to consider for female patients is to make sure we're mindful of sexual activity. So we have to have considerations related to ectopic pregnancy, because while it could be appendicitis, it very much could also be an ectopic pregnancy. It could also be ovarian cysts. So an ovarian cyst ruptures, that can cause lower quadrant pain as well, either in the right side or the left side. It could have pelvic inflammatory disease or other sexually transmitted diseases. And also, don't forget trauma and abuse. So we have a 23-year-old female, and it really doesn't matter her age. For any patient, this could be trauma and abuse. This is why we need to inspect and palpate, because if I'm seeing a bunch of bruising, if I'm seeing bruising in various stages of healing, if I feel that distension and rigidity, I'm starting to think that, hey, this was a patient who was assaulted, and now we're dealing with more of a trauma situation than medical. So let's talk about diseases of digestion. So like diverticulitis. So diverticulitis is not necessarily life-threatening, although it can turn into a pretty serious issue. So your intestines work by moving food through soft muscle folds, right? So you have this smooth muscle that's kind of squeezing and pushing the food down. And as it's doing that, it's pulling out the nutrients and pulling out water to hydrate your cells and hydrate your muscles and just to make your body work. Sometimes food left undigested, so things like corn, seeds, nuts, those are the biggest offenders, will get caught in the folds of your intestine. And since it's caught there, it's not moving past, and other food is, it just can't get out. Think of it like a cul-de-sac, where we just block up the one end and now you can't get back out. It sits there, it festers, it becomes inflamed. With enough inflammation, it can actually rub through your intestinal lining, so it can cause more issues and leak out. In minor cases, a person with diverticulitis may just need to drink a lot more water to try to flush their system out. Oftentimes, they have to get a colonoscopy afterwards and just kind of make sure everything is okay. But you can actually, because of the sepsis and because of the inflammation that's caused by that food particle, you can actually have patients who need emergency surgery and end up losing sections of their intestines. So while it can be very minor, it can be very major. Oftentimes these patients present with just generalized abdominal pain, typically in their left lower quadrant where their small intestines lie, but it can be everywhere. But left lower quadrant pain is typically their main focus of that, but it also can occur on the right, not elsewhere. You can have a patient with food poisoning, so things like E. coli. They typically present with vomiting, diarrhea. If anyone's ever had food poisoning, you know how terrible that is. And then gastroenteritis. And gastroenteritis is nothing more than inside belly inflammation. It's the blanket term for abdominal pain, gastroenteritis. So diverticulitis, food particles stuck in the abdomen, food poisoning, and then gastroenteritis. Our big thing here is either pain management or nausea support. But if these patients are vomiting, if these patients are experiencing diarrhea, or even if they're just experiencing a lot of pain, IV therapy can help because they might be dehydrated. It's not a bad idea to just get IV access simply for pain medication and for Zofran administration. So when we're dealing with nausea vomiting patients, number one thing is, again, vitals. Let's figure out if they are truly dehydrated, if we're dealing with something like hyperemesis, where they're just losing a lot of fluid, put them in that at risk for hypovolemic shock. We can give Zofran either sublingual or IV or IM, right? So 4 milligrams. And if they are hypotensive or suspect dehydration, again, give them fluids. But again, we want a 12 lead EKG. You might be saying, well, they're vomiting. Why do I want a 12 lead EKG? Well, because vomiting in certain patient populations could be a sign of a cardiac event. It could also be a sign of not only just cardiac stuff, but making sure they don't have a dysrhythmia. And it's just a good practice. There's really very little reasons in the 21st century EMS to not get a 12 lead in the field. So let's talk about an abdominal aortic aneurysm. So typically when this is taught, the patient will complain of chest pain, which is possible, but they typically complain of high belly pain. So it could cause a tearing pain in the back between the shoulders. It could also be in the lower back. Typically happens in your descending aorta, and it has 1.1 million cases a year. So there's kind of two types where the aorta itself, so your descending aorta, will start to bulge. And as it bulges, it creates that aneurysm. Obviously, if it pops, that's a major life-threatening issue because you start bleeding out. But typically what happens is it does this thing called, it basically splits down the middle. So your aorta is made up of folds of tissue, and those tissues start tearing away. And as it starts to dissect into your dissecting aortic aneurysm, you actually will create, because it starts peeling itself away on the inside of the aorta, you'll develop two different pipes. So while you have a main branch of your aorta, it's actually pumping two sides of the system because you have a blockage in the middle. What that can do in some patients is create really goofy vital signs. So so if you have a 79-year-old male with back pain, he presents alert and orient ×4 with shortness of breath and discomfort in his middle back. He describes it as sharp and radiates to the center of his upper quadrants. He says it's even almost feels like a tearing sensation. Tearing sensations are going to be like the hallmark sign of a dissecting aortic aneurysm. He's hypertensive, 168/108, good heart rate, good respirations, good pulse ox, and good capnography. So while we might say, oh my gosh, this is an abdominal aortic aneurysm, he's not in shock, right? He's not bleeding out. He's got blood in his system, but there's a blockage within the aorta. Let's say we take these vitals on his right arm. In some patients, and it's a good idea if we have the time, to do a blood pressure in the left arm, and we might get vastly different blood pressures. And that's because 60% of his blood flow might be going to the right side, causing some hypertension, and 40% of his blood flow might be going up the left side of this new pipe, which is going to give a different perfusion pressure. Doesn't always happen that way, does not always present that way, but it has presented that way in the field, so it's not a bad idea to get vital signs on both arms with something like this. Again, nothing I'm going to do for this patient as far as invasive treatments in the field, but again, if I have someone who's hypertensive, they've maybe got some comorbidity factors, they got discomfort in the middle back, maybe radiating a little bit, but it's sharp and tearing, that's a AAA. So let's look at another one. We got a patient who's alert and orient ×4, but they're lethargic, they feel very weak, it just feels like crap. They're dry and warm, there's no trauma. They ask if they can have water because they're very thirsty. There's pain all over, and as we palpate, The most tenderness is near the upper left quadrant. So again, and all these patients, they've all complained of abdominal pain. They've all kind of felt bad. They've all had pain in different areas of their belly, but now we got one in the upper left quadrant. So what's up there? Well, if I look at glass P, I know that I've got gallbladder, liver, appendix, small intestine. Now I'm thinking stomach, spleen, pancreas. So I'm thinking stomach, spleen, pancreas. So this could be food poisoning, this could be a splenic attack, or this could be something that deals with the pancreas. In this case, this patient's dealing with hyperglycemia. So just a brief touch on this, your pancreas controls insulin production in the body. And if you got too much insulin being produced, you have too little glucose. You become hypoglycemic. We get called, we give them sugar, we give them D10, and they perk up because they took too much insulin. You can also have too little insulin, which is what the actual disease of diabetes is. Your pancreas doesn't produce enough insulin, if any at all, which makes too much glucose. Insulin is needed to pull glucose into your cells, every single cell of your body. But without glucose, your cells don't work. And without insulin, glucose can't get into your cell to make it work. So what happens is your pancreas kind of goes into overdrive, trying to pull as much insulin out of it as it can, and can create abdominal pain, especially in that upper left quadrant. Some hallmark signs of hyperglycemic patients is polydyspia, which are their increased thirst, polyuria, and then polyphagia. So they get really thirsty because they get dehydrated because they're urinating so much. And they're urinating so much because their traditional waste mechanism is not working. Their body has gone from aerobic metabolism to anaerobic metabolism. So they're not functioning clean anymore. They're not giving off normal waste products because their cells can't take in glucose. So because they can't take in glucose, they're not making ATP through aerobic metabolism. And since they're not doing that, they go to anaerobic metabolism. It's your backup system. The waste products for your backup system are lactic acid, pyruvic acid, and you put off ketones. So the way to get rid of those, you breathe off ketones by having a lot of respirations called Kussmaul respirations. And then you're trying to eliminate lactic and pyruvic acid by trying to get it out of your system through excretion. So you try to excrete it through sweat, but you've already done that. That's why you're dry. And then you try to urinate it out through your kidneys. This is why diabetic patients also have a lot of renal issues, because those heavy sugar molecules trying to get out of their bloodstream is hitting your kidneys and just trying to work through those little tiny filters that are your kidneys. All this extra urination trying to get the sugar down from your body is going to lead to dehydration. So they're trying to urinate it all out. It's not working. So they take in water because they're peeing a lot. So they get really, really thirsty. And since there's no glucose in your cells to be had, your brain, which craves glucose, is going to be saying, hey, you need to eat. I need sugar. So they're going to eat, which again leads to dehydration, which in turn leads to thirst. So they're hungry, they're thirsty, and they're urinating a ton, all just because of the pathophysiology of hyperglycemia. So how do we treat this? Well, one, I want a glucose reading, I want vitals. So hyperglycemia is typically anything over 140, but if someone just had dinner and their sugar is 190, we really don't care. We care when their sugar is 400, 500, 600, when it can't even read on the monitor and our glucometer just says high. I need IV access, and I want to start giving them fluids because they're dehydrated. And also to try to dilute the amount of sugar that's in the bloodstream, just to try to make them feel a little bit better. I definitely want to get a 12 lead on them to make sure there's no dysrhythmias because their body's not functioning as it should. I definitely want capnography, and then be prepared to provide ventilatory support if they have Kussmaul respirations. And that's why they have rapid, deep, unlabored breathing. Rapid, deep, unlabored breathing, they're just trying to blow off those ketones. So they're just breathing 30 times a minute, just breathing off and to have that fruity odor on the breath. But you can't breathe 30 times a minute forever. And so as they get tired of breathing, they start developing respiratory distress, they go into respiratory failure. So that's why we say be prepared to provide ventilatory support. Really keep a good eye on their airway and their respirations. These patients, these hyperglycemic patients, may progress through DKA or into HINC, which are two different sides of a hyperglycemic patient. Where you're really used to diabetic ketoacidosis, DKA, the HINC side is the same thing, but it doesn't produce ketones. So these are super hyperglycemic patients, but they don't have the fruity odor or the Kussmaul respirations. So what else causes abdominal pain? We talked about it a little bit earlier: cardiac, cardiac, cardiac. Acute STEMIs in the elderly, especially in elderly females, often present or get called for abdominal pain, nausea, vomiting, weakness, all those signs we talked about earlier. So why do I want a 12 lead on an abdominal pain patient? Well, because we want to rule out cardiac. And like I said, in the 21st century, there's very little reason to not get a 12 lead. Now, that being said, common sense needs to have a vote. So if I have a patient with left lower quadrant abdominal pain where I'm pretty sure this is diverticulitis, or I'm right lower quadrant abdominal pain where I'm pretty sure this is an ectopic pregnancy, or I'm pretty sure this is appendicitis, do they need a 12 lead? Probably not. But anytime I'm dealing with my upper quadrants or start thinking of like AAA stuff, I definitely want a 12 lead, if anything, just to rule out anything cardiac. Other signs that the elderly will have, especially elderly females, for STEMIs: back pain, shoulder pain, jaw pain, and of course they do sometimes often have chest pain. Men often complain of indigestion in lieu of classic chest pain. It's more of a defense mechanism, but guys will state they have anything wrong with them other than chest pain because we don't want to believe it's our heart. So they'll complain of indigestion. Again, belly pain run. So that brings us back to we should have a standard treatment plan for abdominal pain. Even though there's a lot of different causes there, if we really look at what's going on, we can affect a lot of change by having a standard treatment plan. So starting with a 12-lead EKG, getting them on Capno to try to rule out shock, get a glucose reading. That way we know if they're hyperglycemic or hypoglycemic or just what their sugar is doing. I want IV access. And then if they're nauseous, Zofran, 4 milligrams. If they have a ton of pain, pain management, ketamine, fentanyl, right? A lot of paramedics were taught and have been taught to withhold pain management from these patients. Well, I would ask, if someone broke their arm, would you withhold pain management? Of course not. Well, even though they don't have a broken bone, they still hurt, and pain is pain. So why would we not give them pain meds? Well, the theory is that, well, if I give them pain meds, I'll mask their abdominal pain symptoms. For those that have had diverticulitis, or those that have had appendicitis, or those that have had just other issues going on in their belly, you give them pain meds, they feel better. If you still palpate the abdomen, they will still feel it. The symptoms might be dulled, but if anything, it helps to pinpoint exactly where their pain is, because we dull those visceral and parietal nerves. Like, so now a physician at the ER can palpate the abdomen and now pinpoint exactly what hurts and get a better assessment tool, all because we did field pain management. Pain management on belly pain patients is a very good idea. And then obviously fluids if they're hypotensive. Most of our stuff is supportive treatment and monitoring, and too often though we don't consider these things. We just say, up, belly pain, BLS. And that's a really poor way of conducting business. In fact, these patients are often ALS patients. They're the #1 cause of surgery. So we should be doing good assessments in the field and providing the best that we can for our patients. Another thing with belly pain patients is there's a lot of protocols, and there's not one single one that deals with abdominal pain. So hypotension and shock, nausea, vomiting, our diabetic protocol, overdose protocol. So if you think of like, hey, I took a bunch of Tylenol, I took a bunch of pills. adrenal insufficiency, hyperkalemia, and sepsis. So we have all these different protocols that kind of warp into things that deal with the belly. Because again, in the abdomen, we have those four different systems: waste removal, endocrine, digestion, and reproduction. So all these things are protocols, but there's not one single protocol to pull from. Since there's not one single protocol to pull from, well, then we have to be good clinical providers and try to assess and determine and diagnose what's going on and come up with our good treatment plan for them based on the limited information that we have. So let's do one more as a group. So we have female patient presents from a local nursing home with a report of bad labs and low potassium. They're altered, which is normal for her baseline. She's got a history of dementia. She's pale, dry, and cool. The nurse reports a lack of a bowel movement in 2 to 3 days. So I got an altered patient. She's 91. She's at a nursing home. She hasn't pooped in 2 to 3 days, and she's got dementia and low potassium. Okay, well, what does that actually mean for us? Well, it means that she might have a bowel impaction. It means that she's got probably some serious issues, because bad labs, again, can't be faked. It's not the annoyance that we get toned for bad labs, it's the annoyance that the local nursing homes and just how things work, they sit on these bad labs for 6, 7, 8 hours. So what are we thinking of with this patient? Well, she's got a blood pressure of 102/60, heart rate of 109 irregular, respirations are good, O2 sats 93, and a CAPNO of 20. So what do those vitals mean for us? Well, again, if I'm looking at a 91-year-old, even if she is on blood pressure pills, like, that's borderline low. So it's a cause of concern for us when we start thinking of, like, what could be causing that? So if her blood pressure is low, or at least borderline low, now I need to start thinking of bleeds, or I need to start thinking that she's losing fluid somewhere. Compound with, she's got tachycardia, right? So she's, even if it's AFib, she's probably going to be AFib, but she's a little tachycardic with that hypotension. She's got a little bit of a low O2 sat, and her CAPNO's 20. So that tells me that this is a shock patient until proven otherwise. So she could be bleeding out, or we could take a temp. But now I'm starting to think either a hypovolemic shock patient or a sepsis shock patient, and both get treated very similarly. But even though this was a bad labs run, this is a septic shock patient. So again, we can't fake our blood. When we have low readings, low potassium, when we have low CAPNO values, it's likely due to sepsis. It could be caused by the abdominal blockage, because the waste has to go somewhere, so her solid waste isn't coming out, so it's backing up in her system. Solid waste could just be festering. She could have ulcers in her belly, which are causing it to leak out. Whole host of different things that could be happening that we just don't know. That being said, this is a sick patient. So if it's a sick patient, what's our treatment? Well, hopefully you're talking about a 12-lead EKG. Again, rule out cardiac because she's an elderly female, but also because she has an altered mental status. So she can't tell us what's going on. We have to do investigative work to find it out. So we'll get that 12-lead. Again, we get a glucose reading because she's altered. We get CAPNO because she's an altered patient. That's how we got that. We notify the hospital, likely a sepsis alert. We get our IV access. We consider some fluids, and then we treat for shock. So again, keep her warm, titrate her oxygen up to 99%. So give her maybe 2 liters a minute. And then again, consider that sepsis alert for this patient. So at the end of the day, the belly gives us a lot of problems because there's a lot of things that cause a lot of issues. There's a lot of stuff in the belly, which all those things have their own independent issues, but we can make a difference with that. So if we understand what quadrant the problem originates in, then we can start to work the issue. I start thinking of my right upper quadrant. Well, glass P, gallbladder and liver. My right lower quadrant, A, appendix. I go over to my left lower quadrant. That's the small intestine. and then I come back up to my left upper quadrant, stomach, spleen, pancreas. And so depending on where that pain is, from palpation, from inspection, I can start to kind of sort of get a at least an educated guesstimate on what could be going on. If we can do that, we can make a difference. And if we can do that, then we can affect patient comfort and outcome. I can consider giving her pain medication. I can start making them feel better, but I'm armed with a lot more information with this patient. Abdominal pain patients are often ALS runs. Is it every single time? No. And good assessment and good common sense has to prevail. But I would dare say that there are more ALS patients that we turn BLS because it's the belly pain run than we do to actually see it through to ALS. So just put in some knowledge in you. Consider that these patients are actually super sick. Even though we can't do aggressive field treatment and fix them in 30 minutes, we can affect how they are going to survive after discharge, how fast their recovery is going to be, and how their recovery is going to be just by doing a good assessment, affecting that patient outcome, getting them pain management where required, getting them pain management where indicated, and making them have a little bit better of a day. Thanks for watching, everybody. I appreciate it. If you have any questions, feel free to get with me. Thanks.